now, I hope.
We can see that perfectly.
Okay, perfect. So I'm going to go into a presenter mode.
Okay.
Very nice. And I just want to start off to provide an introduction. So I think, if I understand correctly, this is a program that targets the primary care physicians. My interest today is to bring in something that is becoming so popular, that is the buzzword of artificial intelligence. But I'm going to focus a little bit more closer to the applications related to medical decision making, and specifically for cardiology. And I'd like to showcase some of the efforts that we're doing at West Virginia University. And then I'll be happy to take some questions as the time will permit. So let's see. Okay, so this is an article about technology-enabled care, the upsurge of mobile technology and mobile health technology that you are so familiar now in the COVID-19 era, where we are doing everything virtually. So we wrote this review article some time back in European Heart Journal of how this was shaping up the whole area of cardiology, and looking at categorization of patients and diseases. So my presentation is going to try to capture and encapsulate some of this application that may be relevant for primary healthcare, and particularly the intersection between medicine and cardiology. And this is typically more useful to understand why this is important, is because we have such a huge burden of disease in West Virginia. And it is expected that by 2030, there's going to be about 4.3 million worldwide shortage of healthcare workers. So you can imagine just like what COVID-19 did for us over a period of time, we will have to look into methods and mechanisms that will allow efficiencies and standardization of processes for recognizing our patients, and using gadgets, which includes perhaps use of technologies like artificial intelligence. And all of us know about the Alexa and the Google Home. How does it work in our homes? The same way, we probably will have technologies that will allow ready and rapid identification of diseases, and also triaging of the patients, which is very important. And it's very interesting that when we have a patient encounter in our clinical practice currently, we spend about initial 60 to 70% of the time collecting data and understanding what the patient's problem is, and we spend very little time on solving the problem. So if there's a way to reduce the time we spend with the patient to quickly jump into, okay, I now understand and I get it. Here are your 3 or 4 things that we need to really address, because this is going to impact your downstream life and your health. If there's a way for us to project that very quickly, that will be really helpful, because we are then in a solving or solution mode rather than querying mode, which is currently what we do. We just keep on looking for diagnostics and trying to understand what the patient's problems are. Some of it is very forthcoming, some of it may be very hidden in understanding the diseases. So it's very relevant therefore for a population in West Virginia, where there's a huge burden of risk factors and cardiac problems, and understanding the risk and bringing people quickly in and triaging them efficiently is what we need to do. How we can do that efficiently is the question that we need to solve. So at the Heart and Vascular Institute, I was very fortunate 3 years back when I moved from New York. I was able to set up a innovation center. Now the innovation center is right across the clinical outpatient where we sit and see our patients. So this center houses in both engineers and also fellows and researchers from across the world who come in and work with us. the idea is that if you have clinicians and engineers work hand in hand, then we can have more rapid translation of the problem. So you can see here some people in scrubs who are the clinicians, and some people who are standing next to them are engineers, and you will see also people from multiple ethnicity, because some of them are from abroad. They work hand in hand, bringing in solutions to the clinical needs. And so we've been very fortunate. We were also lucky to get some funding from the National Science Foundation through our bioengineering programs here at WVU. We came in together, and we are trying to apply artificial intelligence and such technologies directly to patients' care. So what comes up out from the Innovation Center, we try to develop as pilot clinical studies and recruit patients from the clinical environment and vice versa. And one of the programs that we did last year was we curated an opportunity to bring in a lot of people from the community. So what we did was, this was called as the Community Health Outreach Imaging program, is also called as CHOICE. I'm not sure if you would have heard about it. So for 3 consecutive days, physicians, industry partners, community provider, nurses, also primary care health workers, including family medicine physicians, we invited them to work with us in an environment where technologies were incubated for direct medical decision making. And I'll show you some of those technologies that we have used. This was an opportunity to understand how, if you have patients come in, like for example, in an airport, when you come to the kiosk, you do your passport scanning, and you make the process efficient, and then you go to the counter where you have the immigration specialist who can then fast track your examination and your stamping, and then you move in the same way. We did a cluster randomized design in which 2 centers and those were West Virginia University, Ruby Hospital, and UHC Hospital. We had Elkins and we had Bridgeport. 4 places. We randomized people, the sites where people were seen upfront through technologies and then seen by the physicians. And in another half, 2 centers, we had physicians see the patient first, followed by the diagnostics, the way we do in a standardized fashion in a standard of care arm. And during these 2 days, all these patients that were invited and recruited were done through mobile health engagement, where they came in and signed in, and we also took in their own experiences. It also was a very heartening experience for us to see how people were able to learn the processes very quickly. So all of this data has been collected, and patients have been followed for a year, and we are working through the outcome analysis, and hopefully we'll have some work and a presentation coming from this cluster randomized design. But this was again an opportunity, obviously, for me to bring in the nurses and the primary care workers together to understand how some of these processes can be facilitated by using technology upfront. And I'm also equally proud to say that our Innovation Center has consistently produced very cutting edge work. Last year and the year before that, these are the people who have been finalists in a national competition organized by the American Society of Echocardiography. And these all people have been finalists from our lab. And WVU has been finalist for the last 3 years. The Innovation Center won actually the Young Investigator Award. Dr. Kagiyama, and I'll show his work as well. So what I wanted to showcase here also was that the work that we're trying to do, we are trying to share with everyone, but also we take a lot of pride in what we're doing, because I think it sets a tone for others to follow the process. What we do in West Virginia locally probably may have an impact globally, and that's the intent of the Innovation Center as well. Coming to the idea of medical decision making, currently the way we use the medical decision making is typically dependent upon how physician and we do it. So basically, each one of us go through a process of training, right? So we go through either our residencies or our nursing training, practical experiences, or our family residency programs. During those 2 or 3 years, you are continuously seeing patients and setting up and you're training your mind, or you're developing a mental model of patients. After that experience, then when you go out, you compare. I think lifelong we compare a new patient with our old experience, and when we compare with our old experience, then we try to make a judgment, or what we call as a clinical judgment. In a way, if you try to think about it, it's almost developing a model, a mental model, or clinical mental model that we learn over years. And any new patient that comes in, we try to compare it with the previous known model. The more senior people tend to have better clinical judgment most of the time, because they've seen and experienced a variety of patients, and there is a wisdom there, which is gained, which we have gained over a period of time. And many times that wisdom may not be there. So a novice will quickly come into a clinical scenario, not experience that scenario, and they resort to clinical guidelines or documents like from AHA or AMA, and we see try to examine what the clinical guidelines, and that brings in a certain degree of standardization. But the unfortunate aspect of those guideline document is that it is never individualized. It's never a single person. It's almost developed from evidence-based medicine, which talks about an average patient, how they would behave. It's never about a single patient. There are always exceptions. So that's always a challenge, and therefore that lead to suboptimal outcomes. How can we elevate this process? Is there a way we can improve this process? And the answer is there are newer techniques, and that's what we call as artificial intelligence. And the reason we need artificial intelligence is because we also have started understanding the disease, the dimensions of the disease are not just no longer, a disease is no longer a histology slide section, a cross section of a disease like amyloid, the way I learned pathology. That's not a disease. Disease is very dynamic. It has got from genomic to social interactions, and there is data that comes out from each aspect of the disease that leads to a data deluge or expansive sets of information. And depending upon this high dimensional representation, the disease could get very complex, not being just a simple pathology that would diagnose on an imaging or a biopsy. It has got modifiers that come from social interactions, the other risk factors. So the disease has become therefore extremely complex and complicated, and the outcome of the disease or the intervention that you do therefore is altered by presence of all of these modifiers or presence of these dimensions. So how do you come and understand a given patient and his dynamic environment that he lives in? How could you design something for that specific patient? Becomes very challenging. And that's why many times in a very well curated randomized controlled trial, a drug may do very well, but when it comes to real life world, it may not do so well. So this is a big problem that also comes into consideration. There has been therefore an enormous interest in using machine learning or trying to see if the dimensions of the disease can be learned by a machine so that it could predict out not only the detection more accurately, but also the prediction of the risk, the future risk, and also picking up of therapy of interest. So this slide shows the exponential trend ever since 2010, we have seen an exponential trend. And here is a graph that shows not only the number of publications that have grown exponentially, but also particularly in imaging area where my interest is, cardiac imaging area, where you see a huge growth in number of studies that have happened in different fields of cardiac imaging. And when we come to the term artificial intelligence that is used, it's used pretty commonly, but there's a lot of differences in the different terms. Artificial intelligence means applying engineering intelligence to machines and programs to make them more efficient. Machine learning is a subset of artificial intelligence where you learn and give the algorithm, the program, its autonomy to learn on its own without really programming it. So it learns on its own based upon the situations that is presented and comes up with the solution. And you might have heard the term deep learning. This is a subset of machine learning where learning happens in a bio-inspired algorithm. So just like the brain has a network, neural network, we use a same set of chain of algorithms called as a deep neural network, and we develop that and let that neural network learn on its own about a given solution. So that's called as a deep learning. So machine learning, therefore, is a slightly more specialized area of artificial intelligence. And deep learning is even more a specific subset which is bio-inspired by the neural network and the machinery. And the idea is, how could you add the confounders or the complexities, like the clinical factors, the imaging factors, could you add to it other dimensions of the disease, and yet be able to come up with solution or recognition of a patient on an individual basis. So that's the whole idea, extracting information from high dimensional data, yet be able to apply for a given individual. And one another term that is used, and you will hear that, the reason I'm spending some time with the basics is because I think you will hear about this, but typically nobody explains them to a physician so I'm spending some time trying to explain some of this term. Supervised learning is basically when we know about something, we have a labeled data. So we understand, let's say I understand what is meant by fever. I understand the term high blood pressure because I have defined it and I can define it well. So if I can label a data accordingly from my known information and then train a machine learning model to be able to predict it, this is called as supervised learning. So in that process, what we typically do is we take the data, we divide it into a training set and a testing set. In the training set, we expose the algorithm to the label data, giving it the label, saying that this is fever, this is not fever. This is high blood pressure, this is not high blood pressure. This is malaria, this is not malaria. So it trains, it learns from the label data. And in the testing set, we give it the data that doesn't have the labels. So it has to predict it. And once the machine learning predicts the labels, then we compare it with the ground truth and see how its performance is, and we test the performance of the model. So this is called as supervised learning. And there has been a tremendous growth of work in which we have now machine learning models that can identify stuff on their own. So typically what the work a physician would do, be it a cardiac imaging, like an image of an ultrasound system-based image of a patient, it automatically extracts and it can tell you whether this patient has got hypertrophic cardiomyopathy, is there an enlargement of the chamber. So this is currently all available. It's almost unbelievable how fast this whole field has moved in the last 3 years. Currently, there are already algorithms, there are publications, and they're getting integrated in the ultrasound system, where once the images are obtained, the system is capable of providing the labels of a abnormality, presence of abnormality, anomaly, not only doing the measurements and all the stuff, it automatically provides labels. So these are training examples of supervised machine learning, which is very quickly changing the whole field. And where is it going to make a difference? And here are some examples. So for example, we use the stethoscope, or we use 19th century solutions that were used for diagnosing diseases. All of these are getting augmented by application of machine learning algorithms. So for example, there are stethoscopes where the heart sounds can be automatically be recognized by an algorithm. There are images, for example, when you use a fundus examination of the retina, there are absolutely terrific published studies coming that have been published in high impact journal. The AI algorithm can look at the picture of the retina and diagnose, oh, this is hypertensive retinopathy. This is papilla edema. It does remarkably well. So on and so forth, coming into electrocardiogram. Automated electrocardiographic diagnosis is not only there in terms of the EKG detection, but it can actually predict certain abnormalities that otherwise you would never be able to point out. For example, this is a work where you have the ECG. The ECG has wealth of information in terms of electrical signal, wavelet transform or signal process ECG. So Marco, who's a WVU graduate, came and worked with us, extracted all this information from the traditional ECG and looked into a hypothesis. Could it directly interpret the ejection fraction, or could it directly interpret the presence of diastolic dysfunction, presence of heart failure? So these kind of information directly from a simple surface ECG. And what he showed was tremendous. You had simple ECG able to diagnose presence of systolic dysfunction, diastolic dysfunction with great diagnostic accuracies. And some of this work is currently being reviewed and is in press. We have already published one paper in 2018 on some of the preliminary findings. So what I'm saying is, like, think about it. If you had an ECG and you had a machine learning algorithm that will tell you what the echo is going to look like, then probably you will be able to send more patients appropriately towards echo and reduce the cost of unwanted examinations that otherwise are sometimes done, and you end up finding normal study because there's a clinical suspicion, and you could make your suspicion even more perfect by having an AI help you take the decision to gather whether further testing is necessary. So this could be what could reduce the cost. We have, I don't know if this image will work. Oh yeah, it's working. This is a magnetocardiograph. You have heard about MRI. This is not MRI. This is extracting information, the magnetic field around the heart. So this is a scanner that is extracting the magnetic field around the heart. This work is going on right now. Dr. Farjo is doing it. The magnetic field around the heart, and we are training it for detecting coronary artery disease, just like would come from any advanced stress test or even a direct coronary angiogram. So if there is a way for us to extract information non-invasively with no radiation, simply the electrical activity, isolate that information and predict without requiring further downstream testing or stress tests, wouldn't that be more cost effective? So this is another study that's currently is enrolling and is currently being done at WVU. And this is this magnetocardiograph is already FDA approved, because this is an old technology which could not be done up till now, because in the past we didn't know how best to process all of this data, and now we are able to process them because of the speeds of the computers and our presence of artificial intelligence. Same way, moving away from the 19th century solutions of how we diagnose diseases, AI is augmenting the more modern solution. For example, you've all heard about M-Health or mobile health technologies, the sensors, you know, your smartphones having information about patients' heart rate, blood pressure, their sleep, lots of data, but we do not know how do we put them together. Same way, smartphone has been used for extracting now echocardiography. Now we have a tool that can be connected to the back of a smartphone, iPhone, and it converts it into a small pocket ultrasound that you can use in your clinics. So this was the study, a first randomized study, where we took technology from technology-enabled clinics with all this pocket ultrasounds and alive core ECGs and which is extracting ECG from fingers and in activity monitors. They were being used upfront for diagnosing patients with structural heart diseases. And in this particular study that was published, we compared it with randomized with the standard of care methods of seeing patients. And what we found was that in the standard of care clinics, there was a substantial lag in decision making, which led to delay in prescribing procedures, cardiology procedures. In comparison to the M-Health clinic, where there was a quicker triaging of the patients for doing necessary clinical procedures, after over a 1 year follow-up, there was a faster uptake of procedures and delayed uptake of procedures. And this delay in uptake of the procedures and diagnostic testing triaging led to more hospitalizations and death in comparison to the technology-enabled clinic or the M-Health clinic. Again, showing how uptake of technology-enabled decisions can allow downstream outcomes to be more optimized. So this was the first study that showed, and subsequently we have undertaken, as I was talking about, the choice study, where let me see if this works. It may or may not. Yes. So here is a pocket ultrasound, which is a novice. He was never held the probe, is being guided on how to use it. You know, it's like a GPS. The AI is looking at the image and saying that, well, you're not taking the right image. It's guiding the whole acquisition of the pocket ultrasound. Many of you who have not done a pocket ultrasound, have not been trained, could have this GPS allow you to take better images. So it can tell you, guide you, how I can move it up, move it down, so that I can get the information. And what is interesting is that it does not take a lot for you to see after you learn some of these images of the mitral valve and the aortic valve, how it's moving, and you have far more confident resolution and decision towards referral of this patient for further downstream testing like echocardiography or even a cardiology consultation. And this is the study that was done, and some of the people who participated, they really were a big fan of all this modern gadgets. And in fact, after the study was done, immediately there was such a big need that we went ahead and bought some of this butterfly ultrasound examination. And currently there are lots of different companies in Silicon Valley that are also developing some of this guiding or navigational tools for helping people get the proper images as they're seeing their patients. And what I'm saying is, like, this is just the beginning of how appropriate downstream testing could be done, and how you could, beyond just talking to the patient or beyond just perhaps doing it, a physical examination where you're not sure the JVP is elevated or not, you could use some of these gadgets and take care of the patient. And I think there are some interesting situations, and people have thought about, could we do it in telemedicine? Perhaps the patient himself could put the probe and be guided and provide us the information. because there's no examination in a virtual world. So we need some form of technologies like this to extract that information about patients' heart disease or heart failure to be more robust in our clinical analysis. Number three is using the machine learning to improve the diagnostic yield and efficiency of my lab. My lab Echo Lab is bursting with requests for imaging. We have close to about 70 to 80 and sometimes even 90 studies to be done. How can we improve the throughput? And there are now tools that allow sonographers and physicians to acquire the images and get them interpreted quickly, so that the physician is really working at the topmost yield in the day, so that studies can be churned and the whole pipeline can be moved quickly. So improving the efficiency, not only of the traditional study, but also there's work in which even the stress echocardiogram, very complex studies, can be interpreted using artificial intelligence. This is a work that Dr. Nobu Kagiyama did last year, which won the Young Investigator Award at the American Society of Echo, which looked at one more step. Could you look at the texture of the ultrasound images and extract information that would be like MRI, that could tell you that there is fibrosis or more elements of medical decision making, which otherwise would only come from advanced imaging like MRI. And he was fairly successful. He looked at the texture of the ultrasound images and trained algorithms to MRI based information in different categories of patients. And here was the outcome. So these echo images could tell about presence of scars or fibrosis with great degree of accuracy. So this work is currently already published in Lancet eBiomedicine, and again shows the promise of extracting unseen, unknown features which our eyes would not understand, and using that efficiently to deal with how to triage a given patient for further additional testing like MRI. An MRI may not be available everywhere in the community, but if we could make our own ultrasound technologies or cost-effective technologies to extract and give the same degree of information or deal of information, perhaps this could be very important. Diseases are complex, and here is a condition called as aortic stenosis, and the outcome of aortic stenosis is modified based upon presence of other problems like kidney disease, hypertension. They may have cancer, they may have lung disease. All of these are modified. So it's a very complicated patient. When we get a patient with aortic stenosis, some of these other factors can lead to a change of plan of whether a surgery could be done or not. We need some form of better abilities to be able to understand these patients. And this has led to utilization of novel network-based analysis of diseases, in which aortic stenosis can be diagnosed as a network based on a network basis along with its comorbidities. And Dr. Grace Versosa and Suresh Reshta were able to develop a network tomography in which the patients who came with aortic stenosis were seen on a disease cycle. So this is a network that shows the patients seen as dots, and all the patients are connected together by a network and in form of a loop in a circle. Mild disease is on one side, severe disease on the other side, moderate disease is on the top and the bottom. And it's almost like the GPS of aortic stenosis. As the patient worsen, they move from the mild AS towards the severe AS, and they recover back later. Excuse me, I think it's coming back with some, I'm going to just, okay. So this network will allow the disease cycle to be identified. So what we did on this disease cycle that was developed, we looked into patients who had undergone transcatheter aortic valve replacement or surgical aortic valve replacement. And you can see that they're moving from a high risk zone and moving to the low risk zone. these diseases, as they are being identified, each individual dot or nodes of patients has an, excuse me, I don't know why this network is coming in. Anyway, so it is allowing you to recognize patients with their entirety of complexity. So each patient is being has been represented here with all of its information together to recognize the severity of the disease, which is different from the way we diagnose aortic stenosis currently, based upon a few parameters. So based upon the comorbidities and other features, they become high risk or a low risk, mild disease or a severe disease. So it allows you to recognize the complexity of the disease and also assign them to a lower risk zone after their procedures have been done. So this was another way to look into disease model. And you can see here a picture of how we developed it in consultation. Suresh is one of the machine learning engineers, data scientists. He in fact got so good in his work that he was bought over by another company. He has joined another company subsequently. So people are moving in and out, but we are also enhancing their careers and as they're learning from and moving out there. And Martin Tokodi here, who's in here, is now back in Hungary, leading a big research group there. So people are learning some of these processes and going and applying, and worldwide dissemination of the knowledge is also happening. Fourthly, machine learning is really very good than traditional models for risk stratification, and we foresee that that they will become basically the method, one of the primary methods on which you will develop the future risk. And here is a work using computed coronary tomography coronary scores, risk scores. And here is a work that shows that compared to Framingham risk scores or other risk scores, ACC risk scores of detecting outcomes for a patient with coronary artery disease, the machine learning model, the red color, outperform way better than any of the conventional conventional models for predicting future risks of coronary events and death. So this is again an example of how machine learning models are going to perform much better for risk prediction in the future. And Martin Tokodi actually looked into a loop of heart failure patients using this is called as now an unsupervised learning. He identified new patients and categorized them on a risk by a process called as topological network analysis, and where he was able to interject all the technical variables used for describing a patient with heart failure. And after he saw the patients described on this heart failure network, disease network, he found that each of these zones were predicting the future risk of heart failure, hospitalization, and death. So the zone 4, for example, having the highest risk of heart failure death. This is again an example of how future risk prediction is going to be much better after we use machine learning algorithms for predicting for defining a patient risk on an individual basis. Dr. Chris Bianco has been working actively with us to integrate some of the newer technologies in which you can look into the mechanical performance of the left ventricle, left atrium, right atrium, and develop much more integrated framework. But when you can imagine, when all of this information comes to you or a primary care doctor, you often wonder what is relevant and what is irrelevant. Maybe we need to take away the echo report from providing all this technical jargon and give you just the risk labels. This patient is as a higher risk of readmissions and needs to be seen more frequently. That's more relevant. That's what our language has to be in our reporting, and that's what we're trying to develop. And take away all these terminologies of diastolic dysfunction or the complexity or the percentages, which probably are not allowing you to make the decision, which is more important for the patient. How do I use this information to make the decision is probably more relevant. And developing these models, decision-making models, will allow this translation. So once a patient is hospitalized for heart failure and returns back to a primary care provider, All he cares to know is what his probability of a readmission, and if the readmission probability is high, then probably you need to see the patient more frequently than trying to understand what all this report means. So that's the direction towards which we are moving towards, taking away the complexity of the images and the information and developing them towards a model that will speak about the future risk is what is going to happen from you. And here is an example of all this complex information, but ultimately what you're interested is the ROC curve of predicting the risk of a future death or being a high risk phenotype who's likely to have high risk of events in the future. And this is a deep neural network which has been trained, and you can see the blue color. The deep neural network is performing really very well than other conventional machine learning. And there's been a lot of interest in deep learning in the recent past. Not only just taking information from the images, but could you take the text-based information that patients are using on their computers? I mean, there is a wealth of information. For example, how the patient writes to you, or he appears to you, or responds to you, the kind of the language. You could do a mining on those information, on those textual information, and this data, or the way the person speaks, what kind of language they speak. All of these are data that can be used and trained for extracting high-risk behaviors and high-risk phenotypes. And this is something is currently being investigated. Dr. Al-Almoud is working on a machine learning framework to use natural language processing to extract information from text-based information and see if it can provide information about people who are more likely to be defaulting or having non-compliance with drug therapy after they're discharged from the hospital. So these are the kind of engagement, patient engagement devices which can allow us to understand a high-risk patient who's going to probably at risk of non-compliance to antihypertensive therapy or antiplatelet therapy, which will be important for us to monitor over a period of time. Finally, if I'm presenting so much of enthusiasm about AI, does it mean it's going to eliminate us, physicians or nurses or paramedical workers or primary care doctors? And I wrote an editorial recently just in the same contextual information. Could the AI replace an echocardiograph? The answer is no. There are limits of AI that we have not been able to overcome. Now, here is an analogy, and this is Oliver, my son, who is walking, and he's stepped into the big man's shoes, boots, and he does these experiments, and he's walking. The good thing, seeing him walking, we will realize that he learns very quickly. So the human mind is very agile, very adaptable, needs very few data points. I need a few cases of rare cases to be seen, and I can diagnose the same rare case in my future practice. Machine learning is not there as yet. It needs a lot of information. It's data hungry. It fails hundreds of times before it can be trained to do something. So just relax. I think human mind is still very agile, and nothing replaces it. And the current AI is therefore not going to be able to replace the human mind. So what should we then do? Well, learn something that AI will not replace physicians, but I think people who use AI will replace those who do not. So embracing AI in our clinical practice is important, because physicians who are able to use these new technologies probably will be more efficient than who are those who are not using it. So how should we use AI? Well, I think the best application is to use AI to free up time for ourselves from those low-level, repeated, mundane things that you don't want to do. Measurement, data preparation, writing notes, quality control. Those things that you really do not want to do, assign it to AI, because you want to free up time for higher caliber work, higher level of information. Use up the time, free up the time so that you can make up a patient-doctor relationship. You can use that for bringing back joy into what you really like, the human interaction, which the machines cannot do. Machines cannot bring in the kind of sympathy, the care that is needed. So spending more time on human interaction, reducing time. I look into my fellows when I started, they were like buried in their EMRs. The Epic is what we don't need. We need more efficiency so that we are seeing the patient, not our Epic all the time. We want to see the patient. We want to free up time from the Epic so that as we are seeing the patient, data is getting absorbed, collected, assimilated. And this is going to happen. In the next 4 or 5 years, I think somebody's going to say that, I think we spend too much time on things we should not be. I became trained to become a doctor to take care of my patients, not to take care of the Epic. So, well, we have not reached there, so we need to continue to do what we have to do because there's no other solution. So we have to continue to be part of this Epic. But what I'm trying to say is that that's what we want to do the high caliber interactions and connecting with the patients so that they understand. And this patient engagement that happens with the face-to-face contact or even in a virtual environment, the time that we spend on developing this connection is extremely important because that's what dictates the future satisfaction. And if there is a way for us to immediately free up time for doing this high caliber work that interests us, that will be really worthwhile. And therefore we need to partake in this AI and help us in developing the tools that we need now. If we do not participate, the evolution could happen in any direction, and it's very risky. And therefore, that's why whenever I go around, I say that partake in this evolution, participate in the proper evolution of AI so that it develops tools that will be used. Otherwise, someone else will develop tools that we don't want to use. And there's always a risk of different type of biases that can happen in AI. We need to be extremely careful and participate in eliminating some of those biases. And that will allow us to evolve towards a much more grounded evolution of technologies and AI into an efficient world to take care of our patients. Thank you very much.
Thank you so much, Dr. Sengupta. That was excellent. And it always amazes me seeing the advancements and innovation in medicine and healthcare. So, and your son is absolutely adorable. So I appreciate you including that photo of him in there. So I will open it up to any questions for Dr. Sengupta. Donna, did you have a question?
I just had a comment. I really, as a nurse, I'm a disease management coordinator, and I loved when you were talking about instead of just having all the stats and the fractions of the testing, having something applicable for me to counsel my patient on, how coordinate services with the doctor. That would be awesome because that's what I'm trying to do to help decrease readmissions, and having something that is a tool like that can really kind of pinpoint my focus and help explain what needs to happen to make things better for the patient and the doctor. That's wonderful, and I agree, your son is absolutely adorable. Thank you. That was very enlightening. I found it very, very educational, and I hadn't heard very much about this at all, so this was very enlightening.
Yes, thank you.
Mm-hmm. Yes, it certainly was. Any other questions? Please feel free to use the chat feature as well. I could read the question out loud for you.
I'm more than happy to take your questions now and later. I think feel free to share my email, and and in future, always engagement on these kind of platforms is also very important. Continued engagement.
Absolutely, yeah, certainly. And I know you actually addressed the question that I was going to ask. AI, you think would replace, the people who actually, the physicians who do those things. So I appreciate you addressing that as well. So
we need to participate. That's what I always say, because otherwise someone else develops a tool, then it's on me to. I think we need to participate for the proper evolution of the AI to happen.
Right, exactly. And instead of making them obsolete, just enhances their practice. So we did get a question in the chat. What is the rate of accuracy with all the learning that the AI does? And they thank you because this has been so interesting and wonderful.
Thank you very much. So it all depends upon the kind of the tool. So I think when you design an AI project, for example, let me explain to you about the retina fundoscopy project. So what they did was they took a bunch of pictures of the fundus and trained an AI algorithm. And my goodness, their accuracies are like in excess of 0.95, 0.96. I mean, it's unbelievable how accurate they are. So imagine when you use that tool for someone who has never, I mean, all that you need to do is to take a picture and then you use the gadget and it tells you, is it a hypertensive retinopathy or not? So many people are going blind and they cannot even have an ophthalmological examination. So think about a tool like that. And somebody is actually developing a tool to develop it on a smartphone. So you can do on a smartphone and you can have a fundus examination and you know the hypertensive presence. This is unbelievable and the accuracies are very, very high. Typically when you compare traditional models, statistical model or an AI model, AI tends to perform better, but not always. So there are some places, even the traditional statistical model tend to work. It all depends upon the kind of how do you set up the machine learning process. But there are lots of great examples. Like I showed you the echo image. So it's kind of guiding. It's on real time. So these AI techniques are being used in smart cars, right? I mean, you will be amazed. Like your sensors in the car sometimes are giving you that information. Sensors in flights are being trained by AI to drive. I mean, the pilot is not continuously monitoring the airspeed, and I mean, you're getting this information, and then there's a AI and some of this has led to crashes also. I mean, that's the danger of the AI. But what I'm saying is we use it a lot. Unknowingly, we are using it a lot. So AI can be very accurate. And depending upon the technology, there are risks, but I think there are also tremendous benefits. I hope I answered that question.
Sure, thank you.
How many people are there in this call right now? Because I can't see all of them.
Sure. So we had about 1, 2, 3, 4, about 6 on the call, and I think one actually just had to leave maybe to see a patient. But yeah, we had 6 on the call. So thank you. We do record the audio and the video and post it on our YouTube as well. So a lot of our clinicians go back and rewatch it when they have some free time, maybe during their lunch hour. So
great.
Post that. So I was just going to say we have about 4 minutes left. I know you touched upon biases that may, arise with AI, but do you believe that there could be any ethical challenges that some clinicians may need addressed, and maybe the AI doesn't perform as intended or could potentially bring any patient harm?
Yes. No, there are definitely biases. Like I think there are some very classic examples of biased AI in the literature. Machine learning, on the Google AI, when they tried, you have seen the Google AI, it automatically tries to label patients, people and subjects and all. I think when it was trained to identify, it looked into the Afro-American fraternity and it labeled them as gorillas. It could not. It was the biggest error ever done. The same has happened, and particularly in a community, in a diverse ethnic environment. These are very big challenges and ethical questions. So, AI was trained by police, I think in San Francisco, and for some reason there was a higher likelihood of it predicting criminal category to people with certain ethnic background. So that was a risk. So what I'm saying is that like they are biases. How you train it depending upon the kind of the underlying. So the person who trains the model, his own biases can get into the model. So you have to be extremely careful when you there are biases that can unknowingly creep into a model. So one of the things that we always advocate is that whenever you develop a machine learning algorithm, you test it in different scenarios. So for example, what is developed in West Virginia may not be applicable in Arizona. So if you want to really say that this is a great machine learning algorithm, you have to test in multiple scenarios, be satisfied before you really say that this works. If it is not working, go back and retrain it until you're satisfied. So yes, so there are biases, and how you test it, how you develop it can really make a difference. And that can lead to ethical challenges. There is also lots of challenges related to patient-related information leaking out and privacy, patient privacy. These are some of the bigger areas that we need to have definitions, and there has to be the community addressing of what is. There's a hairline difference of what can be allowed and what privacy laws cannot allow. So I think these are the areas we all need to participate in. But in best scenario, I think an individual patient should be in control of his own data and his own information.
Absolutely. Thank you so much for addressing that. And thank you so much for the entire excellent didactic. I know we had really great feedback, and everyone appreciates it so much. And Caitlin chatted in saying our last cardiac health echo we posted on YouTube had 47 views. So I know a lot of people will be going back and rewatching it, and watching it on our YouTube as well. So thank you so much for your time. Thank you everyone for participating and joining in today. Just one quick announcement before we part ways. Our next session will be on July 17th. And that's because the July 3rd one is canceled due to the holiday. So we will see you guys on July 17th. Thank you so much, Dr. Sengupta, and we will see you all next time.
Thank you very much.
Thank you. Bye.
Thank you.